Thank you for an introduction. Assalamu alaikum wa rahmatullah. First, I would like to thank the organizing committee for great hospitality, excellent organization, and the wonderful dinner last night. Regarding breasts, to target any tissue, we need to study the biology of the cells. And the breast cells are very complex, and the biology is complicated. For example, cellular alteration are due to molecular alteration. There are too many proteins. They altered and they get mutation and they promote some genes like proto-oncogene and oncogene, etc. So five main classes of protein alteration are growth factors. Growth factor is receptor, a protein kinase, or protein that activate protein kinase. A protein that controls cell cycle, like cyclin D. A protein that affect apoptosis. So the three mechanisms by which accumulation mutation can occur leading to cancer are transformation of normal gene into oncogene. Some examples of these are cyclin D or HAR, loss of function of a tumor suppressor gene. B53 mutation is responsible about 50% of all cancer. So when it's mutated and the mutation of B53 that it leads to a lot of phosphorylation. That's why sometimes you see uptake in MDP-Scan with a breast cancer patient. So, and the damage in DNA repair mechanism. So all these, the radiopharmacists and radiochemists and chemistry and biologists, they are working to target these protein. So they sit together, they discuss, and they try, and they do. There are too many research going on worldwide. So there is a chemistry Nobel Prize being given 2012 to Brian and Robert, explaining the couple receptor G protein. As you see here, the interior, the light blue, and the interior of the cell, and the exterior of the cell is the blue. And you can see here there is a glycoprotein here, and the yellow one are the receptor. So once any mutation or alteration happen within the cells, with the mutation, that's lead the receptor to go and bind to the ligand where it activate the growth receptor, the G protein. And once it's activated, too many signals goes and alteration happen, and sometimes it lead for phosphorylation or apoptosis, cell death, or DNA changes. So almost all drugs, radioactive or none, bind to plasma protein. So it's all about protein binding. So if we first talk about Tc-MIBI, technetium Tc-MIBI lipophilic cations. And if you see here how that Tc-MIBI goes to the cell, it's +1 Tc-MIBI, and interior the cell with the activated G protein is negative, and the mitochondria is more negative, so the potential it goes from outside to the inside, and that's what keep the MIBI inside the cell. But just to say that MIBI is non-specific actually to differentiate between malignant or benign. But any mutation or something in the cell that's lead to the changes in potential leads to concentration of MIBI inside the mitochondria, and also can be used for follow-up or after treatment baseline. As you see, I have chosen good images just to show the uptake. But there are limitations to Tc-MIBI, like biodistribution, hypoxia, uptake and apoptosis, anti-apoptotic protein, BCL2. This is affect mitochondria and prevent MIBI. So it's give passive diffusion. Efflux, expression, overexpression of G protein bump the cell and maybe out of the cell. So if you see here, it's the same mechanism, but there is active efflux, which is due to apoptosis, where it lead to push, due to overexpression to G protein, it's push the maybe outside. So it goes in and get out. It doesn't localize in mitochondria. The other one is the apoptosis. The apoptosis, there is no potential, so maybe cannot concentrate there. And that's why there are antibody used when it's apoptosis for scanning. So the new one, which is still under development, is modified peptide. If you look to the right image, is the MDP-Scan. And most of breast cancer patients, when you do MDP, you see just increased uptake in the affected breast. NPY-P, the modified peptide, is small molecules, but it acts exactly as peptide. It's about 30 minutes preparation, and the synthesis of carbonate MBI analog. So here again you can see more than one example of a distribution. So high receptor selectivity actually for MPI. Sentinel node scintigraphy is become just part of the practice, care practice. So using nanocolloid injection, just subcutaneous surrounding the tumor, and imaging. Sometimes we need to, sometimes a marker on the skin. But what about lesion and palpable? Those they cannot, or deep inside. So there is something called radio-guided occult lesion localization. Occult lesion is the one that cannot be palpable. So it's injection of MAA directly into the lesion by ultrasound guided, and then within like 18 hours or something, a patient goes to the surgery and use a probe, and this, just in the surgery is just a small. The reason for that is in the surgery sometimes you need to keep the lesion in the middle of the excited tissue. So without having guided by MA or something, sometimes doesn't keep the safe margin around the cell. So we go to PET radiopharmaceutical. There are too many parameters to use in PET parameters. Amino acid, receptor, glucose consumption, cell membrane synthesis, proliferation, and too many more. So parameter used in PET to develop radiopharmaceuticals. So FDG is well known, and it's one of the main practices, and it's used in PET imaging also, breast imaging, especially with some tumor consumption. Most of the tumor, especially if it's supplied and perfused, sometimes FDG uptake is there. Most of you, they know the mechanism of FDG, why it's not get metabolized. So it when it reaches 6-phosphate, it stop there. So, but the ligand in oncology, like thymidine analogs, which is our interest in the breast, FLT is a measure of a proliferation in tumor cells. So, and as we spoke in Tc-MIBI, if there is a proliferation, it cannot be taken by Tc-MIBI. So, FLT, there are two way of synthesizing FLT, one with low yield and one with higher yield, about 13 to 50%. The FLT is thymidine phosphate when it's phosphorylated by thymidine kinase and attracted by the cell and stays there. So the other one is Fluoroestradiol FES, better estrogen hormone, easy labeling, and some of breast causes are the stimulation of the hormone, and usually in bone scan when it's due to this hormone, usually we don't see the uptake. So you see this FES, there is bone metastasis. Too many causes and alteration in cells and biology lead to many receptor. So too many receptor need to be studied more and more to find the right diagnosis. So I'm moving to intraoperative avidination for radionuclide therapy. This is the reason for this is there are therapy in neurotherapy. It's been used since 2004 in Milano, Italy, Institute of Oncology, where I got training there. So usually in I.A.R.T, the surgeon just distribute the AVIDIN. AVIDIN is a protein. So positively charged. It's always chemistry, positive and negative. So AVIDIN injection during surgery into the tumor area. So AVIDIN is subunit molecules. AVIDIN-BIOTIN complex is the strongest known non-covalent interaction. As you see, the biotin, 4-biotin can bind to one molecule AVIDIN. And it's very unaffected by extreme, very stable, unaffected by temperature or pH or organic solvent. So this is the molecules of dotabiotin, which is labeled with lutetium, yttrium, or indium, any metallic ion. So these are, most of you knows the characteristics of lutetium and yttrium. So how avidination in the operative room, as we mentioned earlier, into the breast, the AVIDIN is distributed homogeneously. Now they developed with multi-hole needles to distribute the AVIDIN more there. How that works? Usually the surgery, the excited part is inflamed, so it's negatively charged. So the surgeon just inject AVIDIN over the surgical part. It's positive, it's bind there. And they finish the surgery, they close the surgery. Second day, patient comes to nuclear medicine and get biotin labeled with radionuclide. And as you see here, this is one of the first cases used indium to see the effectiveness of this therapy, and now it's become routine. You see there, in a few hours, most of the distribution in the breast area where the surgery is site. So why is that? Is to deliver dose and to, instead of external beam radiation therapy, high radiation dose might reach up to 5 gray. So in conclusion, molecular imaging in breast cancer is non-invasive, sensitive, quantitative and peto respect, flexible in differentiating tumor targeting tracer, important tool in cancer patient care, and improve understanding tumor behavior. We always look for other tracer and research is going on. And thank you for listening.